This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub Podcast. I'm Dr. Aris, a senior attending here, and today we are diving into a topic that remains one of the most challenging areas in our field, the management of third ventricle tumors.
And I'm Dr. Elara, Research Fellow. Today we're looking at a fascinating new study from the journal Neurosurgical Review, published in 2026, titled Surgical Strategies and Long-Term Survival for Third Ventricle Chordoid Gliomas, a Systematic Review in Clinical Algorithm. It's a paper by Elara and colleagues that provides what I believe is the largest systematic review to date on this specific pathology.
This is a timely discussion, Elara. For the residents listening, chordoid gliomas are relatively new to our lexicon. They were only first defined as a distinct clinical pathological entity by Bratt and his team back in 1998. They are currently classified as WHO Grade 2, but as any surgeon who has encountered one knows, that Grade 2 label can be deceptive given their location.
Exactly. They are rare, low-grade neuroepithelial tumors, but they arise in some of the most expensive real estate in the brain, the anterior wall or roof of the third ventricle, often right near the lamina terminalis and the hypothalamus. The Elara study looked at a cohort of 198 patients, which gives us some really robust data on who these patients are.
What did the demographics show? Usually, we think of these as adult tumors.
That holds up. The mean age was 41.8 years, peaking in the 4th and 5th decades. Interestingly, there's a clear 2-to-1 female-to-male ratio. Clinically, they present exactly how you'd expect for a mass in the diencephalon. About 51% had headaches, likely from obstructive hydrocephalus. 37.5% had visual disturbances from optic chiasm compression, and nearly a quarter, 24.4%, presented with cognitive deficits.
And that's the difficulty. By the time we see them, they are often solid, well-circumscribed ovoid masses. On MRI, the paper notes they are typically iso-intense on T1 and show vivid contrast enhancement. But the radiological diagnosis can be tricky. They can look like craniopharyngiomas or even meningiomas.
That's where the pathology becomes so critical. The study highlights the unique immunohistochemical profile, diffuse expression of thyroid transcription factor 1, or TTF1, and GFAP. The researchers also mentioned the theory that these tumors share immunophenotypic features with the organum vasculosum of the lamina terminalis, the OVLT, which supports a very specific embryological origin.
Let's get into the meat of the paper, the surgical dilemma. As neurosurgeons, our instinct is often gross total resection, or GTR, for a WHO Grade 2 lesion. But the paper frames this as a major therapeutic dilemma. Elara, what did the survival data actually show when they compared GTR to subtotal resection?
This was the most striking part of the Kaplan-Meier analysis. They found a significant survival advantage for GTR. The 5-year survival rate for patients who underwent GTR was a stable 91.9%. Compare that to only 54.7% for those who had a subtotal resection, or STR. The p-value was 0.0089, so it's statistically very significant.
91% versus 54%. That is a massive gap for a low-grade tumor. However, we have to talk about the cost of that GTR. The paper is very clear about the intimate adherence these tumors have to the hypothalamus and the optic apparatus.
Right. The authors point out that while GTR provides the highest probability of progression-free survival, the aggressive attempts to achieve it often lead to severe postoperative morbidity. We're talking about permanent diabetes insipidus, hypothalamic obesity, and those severe short-term memory deficits that can be devastating for a 40-year-old patient.
It's a classic surgical selection bias problem, isn't it? The paper actually acknowledges this. They mention that the survival association might be confounded by tumor adherence. In other words, if a tumor is less adherent, it's easier to achieve GTR, and those patients naturally do better. If the tumor is stuck to the floor of the third ventricle, we settle for STR, and those patients might have more aggressive biology or more complications anyway.
Exactly. And because of that, the study emphasizes that resection strategies must be strictly individualized. They don't just say GTR for everyone. They suggest balancing tumor control against hypothalamic morbidity.
Let's talk about the surgical corridors the paper mentions. For the residents, choosing the right approach is half the battle here.
The authors reviewed several corridors, the transcallosal, the transcortical, and the translamina terminalis. The choice usually depends on the tumor's vertical extension and its relationship to the foramen of Monro.
I find the translamina terminalis approach particularly useful if the tumor is sitting low. But if it's pushing up into the body of the ventricle, that transcallosal route gives you a much better view of the secondary attachments. Now, Elara, did the paper touch on molecular markers? We're seeing more and more of that in neuro-oncology.
It did. This is a key area for future targeted therapy. They identified the PRKAA D463H mutation as the predominant driver in chordoid gliomas. They also noted BRAF V600E in a small minority of cases. Having these molecular profiles in the review is a huge step forward for potentially managing patients who aren't candidates for aggressive resection.
That's interesting because, as the paper notes, the role of adjuvant therapy like gamma knife or fractionated radiotherapy remains ill-defined. If we have a PRKAA mutation to target, we might finally have an answer for those STR cases where the tumor is too adherent to the hypothalamus.
Definitely. The study also mentioned that GTR was achieved in 56% of the cases they reviewed, while 32% underwent STR and 10% were biopsy only. That's a fairly high GTR rate given the risks, but it also shows that in nearly half of the cases, surgeons felt that a total resection just wasn't safe.
And that's the wisdom in this paper. It doesn't just give us a survival number, it gives us a clinical algorithm. It's about the balance. If you can get it all safely, the long-term survival is excellent, over 90% at 5 years. But if you're pulling on the hypothalamus, you're trading survival for a quality of life that might be unacceptable.
To summarize for our listeners, Alamare et al. Have given us the largest dataset to date on these rare tumors. We know they are TTF1 positive, often driven by PRKAA mutations, and while GTR is the gold standard for survival, the individual anatomy of the patient's third ventricle must dictate the limit of the resection.
A great deep dive into a very difficult pathology. For our residents, remember, grade 2 does not mean easy. It means we have a long-term responsibility to the patient's endocrine and cognitive health.
Thanks for joining us on the Neurosurgery Hub Podcast. We'll see you in the next episode.
Goodbye, everyone.